The next two, it's all going to be one section broken into two parts. And this one today will go by pretty fast. The second one, maybe not so much. There's going to be a lot more to that in depth, and it's really going to apply to you guys in part two, getting into triage. And it will go over a lot more of some of the more, I guess, gruesome things you may see also. But this is where we're getting into the important stuff that CERT team members perform during a disaster. Medical operations, when you are the first to arrive, before professional responders arrive, and you're looking at this big old mess, and now you have to learn how to sort through it. And when I say mess, you're dealing with death, destruction, serious injuries, and a lot of them. It may not be just one or two people from a car accident. It may be 20 people. One of the biggest triage operations that I've ever been a part of was when they evacuated due to Hurricane Gustav in Louisiana, and they started flying people up here on Air Force planes. They had ambulances from all over the state come up here to Little Rock Airport, and as soon as the plane would land, we would have to go on board those big airplanes, and you may have 200 people on board that aircraft that was evacuated from a hospital. And you've got to know who goes first and who can ride a bus. Some of those people, if they can walk off that airplane, they're getting on a city bus and they're going to go sit in the waiting room at the ER. It frees up the ambulances. So we're going to talk a lot about that. We're going to talk a lot about some of the things during this after you get somebody triaged. And you set up your treatment areas and where you're going to do this. Some of the treatment things that you do for life-sustaining treatment. We're not worried about minor injuries at this point. We're going to be focused on things just to keep people alive. So, the need for CERT members to learn disaster medical operations is based on two assumptions. The number of victims could exceed local capacity for treatment. Like I said, literally, we may run out of ambulances if it's something big. You guys remember when Flight 1420 went down at Little Rock? Okay, just so happened that night, they didn't have enough ambulances on the street for that amount of people. And so you're having to call in resources from other counties, from other jurisdictions, and it takes them a while to get there. And so the ones on scene are just trying to do the best they can with what they've got. So it may overwhelm. The survivors will assist others. Don't automatically assume that if a survivor, if someone that's a walking wounded who is, ambulatory and able to walk and they don't have serious injuries, that they are going to just start helping other people. It may not be the case at all, so don't assume that. They need to know life-saving first aid or post-disaster survival techniques. This is where you guys come in. You guys have to be the ones to have that set of skills to kind of keep everything running. Phase 1, death within minutes, results of severe trauma. Phase 2, death within several hours as a result of excessive bleeding. And then Phase 3, death within several days as a result of infection. One of the things we will go through in disaster medical operations is hygiene and how to keep people's goo from interchanging. Because they may not have a life-threatening injury. It may be that they do have a pretty severe laceration or a cut and normally be treated well and everything be good, but in that environment, getting cross-contaminated, and then all of a sudden they develop a serious infection that's fatal to them. So we're going to try to talk a little bit about that also. Treatment for life-threatening conditions: airway, obstruction, bleeding, and shock. These are going to be the key things that you're going to have to look for and you're going to have to treat. An airway obstruction, air's got to go in and out. You got to have it. And if that's not taking place, you have to stop right there what you're doing and try to get an airway. Second thing is bleeding. The blood's got to go round and around. If there's a hole somewhere and it's not completing the circuit, You got to fix it. And then shock. Shock is one of those things that's real tricky. There's different types of shock. But whenever you have a traumatic shock, and what that is the body's not getting the blood it needs, pretty much. And there'll come a point when it's irreversible, and it kills tissues, it kills cells, and they will die. Even if you do treat them, it may be too far gone. So shock is a real important thing, and we'll talk about that.
What are some of the symptoms of shock?
We're going to go through them.
Okay.
We're going to go through them. So there's this little acronym called START, Simple Triage and Rapid Treatment. We're going to go, like I said, in part 2, we'll go a lot more into triage and how we're going to do it and all that kind of stuff. But what triage is we're going to sort them out based on how high their priority is for treatment. And then rapid treatment of the injuries assessed and prioritized in the first phase. Remember the first phase up there, well, those are the ones that are absolutely immediate. So what's some of the objectives of this particular section? We're going to identify the killers. The one thing that when you are dealing in a disaster environment that is a killer to another person. Applying the techniques for opening the airway, controlling the bleeding, and treating for shock, and then conducting triage under simulated disaster conditions. We're going to do that during practicals. You won't have a bunch of bodies laying out there, but what you will have is you'll have a bunch of water bottles laying out there that will simulate bodies. And there will be a little card on that bottle. And it's going to give you all the information that you need about that person. And what you will have to do is work as a team to properly triage that scene based on the injuries that you have read. So, treating life-threatening injuries, triage. Okay, we talked about these 3 killers. These are the things: airway, bleeding, and shock. Those are the main focus. If somebody may have an amputated extremity, but if it's not bleeding, then it's not life-threatening. Okay? We can wrap it and go on. But if they're not breathing, or if they've got a femoral open, or one of their major arteries is open, you got a serious problem. First priority of medical operations, we can do that. How to approach a victim. Okay, when you get here, these people are beyond scared. Some of them are just in a daze. When you walk up to them, let them see you. Let them know who you are and who you work for. A lot that goes into this will be the stuff that you're wearing, your helmet, your vest. They're going to look at that and know, obviously, you're here as part of an official capacity. But you want to let them know who you're with and let them see you. You got to ask them, if possible, if they are alert and coherent, request permission to treat them. It may mean somewhere in one of their, it says cultural difference, maybe their religious beliefs. They don't believe in you performing certain maneuvers on them. And they may just say, it's my God's will and let me go. And you got to respect that. Now, I'm sure y'all covered this. There is what is known as the implied consent law. The implied consent law means that anybody that is unconscious in that situation would imply that they would want to be treated under those circumstances. And so you can take action. If someone collapses from a heart attack, chances are they're going to want you to help them. It's implied. And you can act under that without fear of getting in trouble for that. So, again, always tell them who you're with, what organization you're with. Ask them if they want help, if they need help. And then just try to respect any differences. First things first, airway. The airway system in a human is very complicated. A lot of stuff going on in there. A lot of ways it's very fragile. Some people that have asthma know just how fragile it is. A lot of elderly folks, COPD, things like that, very fragile. So anytime something happens serious where it interrupts a person's ability to breathe, almost 95% of the time, when a person can't breathe, they will panic. And so that's why it's really important to go ahead and maintain an airway. An open versus an obstructed airway. Most of the time when somebody's laying on their back, and part of this is you got people that snore. You know, so when people snore, that whole what it is because it's their tongue is obstructing their airway. Back there, they're laying on their back and their tongue's laying on the back of their airway. And whenever somebody's passed out, or they're all contorted up, their airway is obstructed. They may have the ability to breathe if someone could help them and open it. Now, the head tilt chin lift method. How many people in here have had CPR? Okay, we all are on the same page. Everybody knows how to do the head tilt chin lift. One slide that they don't have in here is what is known as a jaw thrust maneuver. If you suspect somebody has a serious head or spinal injury, obviously you don't want to go jerking back on their head. So there is a way right back here to push on the jaw and push up. And that is called a jaw thrust maneuver. And that is for people who are suffering from trauma to the head and to the back. Types of bleeding will go from the really bad to the not so bad. Arterial bleeds. Arterial bleeds are probably the worst you can have. These are the ones that, if you have a tourniquet, these are the ones where you're going to want to strap it on. There's a big move right now. Used to, tourniquets were all the rage and they'd use them, and then all of a sudden they came out and they said, tourniquets are bad. If you put a tourniquet on, they're going to lose a limb. Now, they're coming back after studies and saying, well, that might not be the case. And now you're seeing a lot of police officers carrying a field tourniquet in their pocket. Because now was it Conway where they saved one, or Little Rock where the police saved one?
It was, Conway, because Conway carries them on their person.
The police show up, guy's got an arterial bleed, he's going to bleed out in a matter of minutes. And they put a tourniquet on, they saved his life, and they saved his limb too. So it's not like what they thought. They're teaching SWAT medics, they're teaching SWAT officers, they're teaching patrolmen how to use tourniquets now and to use them properly. And this is something that if you take that training later on, that specialized training later on down the road, it's something that could be very beneficial. And knowing when it's an arterial bleed and when to apply something like that. But if you don't have it, the best thing you can do is pressure. As much pressure as you can muster on an arterial bleed. The next, venous bleeding. It kind of flows. You know, who people have ever gotten stuck with an IV, and when they pull that out and they don't get it cleaned up in time and it just flows out, that's a vein. That's venous bleeding. And then capillary bleeding is, you know, when you cut yourself shaving, it just kind of oozes out, or whenever you poke yourself on the end of the finger and it just kind of oozes out. It's capillary. Arterial, it's going to spurt. I mean, you're going to see the heart pumping it out. And it's bad. Capillary, not so much, and then venous, a little bit more. 3 main methods to control bleeding. Direct pressure, you've got to put pressure on it. The bigger the bleed, the harder, the more pressure you want on it. Second is to elevate it. You might not be able to, if it's a serious bleed in their groin around the femoral, you might not be able to elevate it. You may have to elevate their torso or whatever you can to get under them to elevate. You just have to improvise. And then pressure points. And to give you an example of that, start from there. Say you don't want to put you've got direct pressure on it, but it's still going pretty bad. And we'll say he's got a bad bleed just coming out right here. There's a brachial pressure point right there. If you will cinch down on that, along with direct pressure, it will slow the flow of blood to the wound. And so you have to find that pressure point on the body in relation to where the injury is. And it's going to, like I said, a team effort. It's going to be a buddy system to try. When you're dealing with a big bleed like that, you're going to have to work together. Right here, like I just showed you, the brachial, the femoral pressure point, and the popliteal pressure point, which is back here. If you can get a hold of one of those pressure points, get pressure on it and get pressure on the wound and get it elevated, you can really stop the flow of blood. If you want to cheat and you just want to spend the money, it's not overly expensive, and you get trained to use it, they make a thing called quick clot. Medics use it, SWAT teams use it. It is a medical product that police mainly use it in gunshots. It's a kind of a sandy kind of substance, and you pour it on the wound, and it will clot the blood. It does. But, and here's the thing, when you're using it, I don't care if I'm burning them and it hurts because it burns, it's working.
Yeah.
They're not bleeding. It does. It clots the blood.
Something that can be,
The same thing that uses nails, just fresh off.
And we'll go a little bit step farther with this for a minute. We'll talk about, I use gunshot as a reference. Folks, if we have an active shooter on this campus, people are going to have gunshot wounds. I can tell you one of the most effective things for a gunshot wound when we're talking about bleeding control, a tampon. A tampon is designed to absorb blood. So, if you, and you look at a lot of SWAT officers and stuff, they'll carry them in their pocket because they know how effective they are. So that might be a little something you want to throw in your go bag when you get it, just as in case. So, okay, shock. I talked about it. The result of ineffective circulation. The blood's not getting where it needs to be. You see it most time. You all of a sudden, people or you watch movies and they're all in shock. They're going into shock. Well, it's not that they're shell shocked and they're just kind of out of it. No, what's happening is their tissues are dying, their cells are dying, parts of the body are shutting down slowly due to ineffective blood. They may have internal bleeding going on that you don't see. That may be what's happening. And if the blood's going, say, into the stomach because they've got an internal bleed, then it's not going to the liver, it's not going to the kidneys, it's not going where it needs to go. What you'll wind up seeing in something like that is they'll start their midsection, all four quadrants will start getting really hard depending on where it's at. And when we start talking about patient assessment, when you're doing a head-to-toe assessment, you're going to be feeling for this. And you're going to feel, and you may say, they're really rigid right there. And all of a sudden they're kind of swelling and everything. Chances are, if they have an internal bleed, you've got to start treating them for shock. And like I said, we'll get to more of that. Like I said, it'll kill entire organs. Now, what happens when you kill the liver and a kidney and something else. There's no coming back from that. And you just can't revive the organ once it's dead. So the main signs of shock: rapid and shallow breathing, capillary refill. And I don't understand why they put cap refill in there when they don't give you an explanation of what it is. You guys, whenever you push down on your finger and it turns white and you let off of it and then it turns back red again, that's capillary refill. And EMTs, paramedics, they test that cap refill to see how quick the blood comes back to how well it's circulating through the body. And if the capillary refill, if it takes longer than 2 seconds for that to turn back to its normal color, that may be a symptom of shock. And what that's saying is there is a delay in how long it takes to get the blood back there. Failure to follow simple commands such as squeeze my hand. If you're talking to them and it's almost like they went strokey and they just can't comprehend what you're saying, again, the blood's not going to the brain, so it's not acting like it's supposed to. It's another thing to pay attention to. They can be missed in a chaotic, stressful environment. You may just chalk this up to they're scared, that's why they're breathing so fast. It may be that they're just scared to death and they're screaming and they're in pain because their leg hurts and they're just not listening to what you have to say because they're more focused on their leg. You kind of got to be able to read through that a little bit and say, okay, yeah, I know your leg hurts, but squeeze my hand for me. Just calm down, squeeze my hand. And if they can't even do that, then you may need to say, okay, we got something else going on here.
So since it's all about blood flow, so then if somebody has bled a lot, we should especially check for this, or if somebody's having a cardiac episode, this can happen.
Absolutely.
But this isn't just panic attack.
No.
Okay.
No.
So it can't happen from like psychiatric trauma, and it can't be a result of that.
Depending on the type of burn, yes, and we'll get into burns in the second section. Anytime you have a major trauma to the body,
Where a lot of blood is lost.
where a lot of blood is lost, or not necessarily a lot of blood. I mean,
Babies only have to lose 30 ml.
yeah, a small baby has a lot less blood. Don't take them nearly as much. And so, anytime you have trauma,
Internal bleed, like we might not even see it.
you may not even see it. Correct.
Okay.
And so, it's always a good idea just to treat for shock. Hey, it's one of those things where it doesn't hurt to treat it anyway. So, responding to a mass casualty incident, such as this, what we're talking about here, when you've got a lot of people that are hurt. First thing you have to do, again, have a plan, follow that plan, and then document your actions throughout, which is something a little different than before when we talked about fire suppression. When you get into this and you have 30 to 50 people that you're having to try to take care of and sort, documentation is a very, very important factor. It may mean that all you do is take a clipboard with a piece of notebook paper and draw you some lines on it and make you a small grid and just start marking what you're doing and documenting. Because when people get here and they're trying to get them sorted and treated and transported, they need to kind of have an idea of what you've already done. Or whenever they get there, they don't want to be spending their time re-triaging whenever they need to be transported or treated. So if you document what you've done throughout the entire time, all you have to do is hand it to the incident commander whenever they take command and say, this is what we've done so far. So, we've seen this. You're probably going to see it again in just about every section. Gather the facts. Know how many patients you have. Assess the damage. If you look out there and you see automatically about 5 people dead. It's pretty bad. Consider the probabilities. How many are we going to save here? Establish your priorities. What would, not necessarily rushing out and treating people may not be the priority. The priority, number one, is going to be, is the scene safe for you to work in? There may still be a lot more going on, and it may be just too dangerous for us to go to work yet. That may be the first priority. The next priority may be, we have nobody can get to us. If it's a tornado and there's damage and roads are blocked and everything else, something to think about. What's the priority? Making decisions. Again, we talk about somebody's going to step up and be the team leader and say, okay, we got to do this. Develop that plan of action. Say, okay, you're going to take this side, you're going to take this side, and you're going to move from the front to the back. Triage. Actually do it and then evaluate it. Evaluate the process. Do we need more people to come in and help triage? Are we getting them moved out of here pretty fast? These are going to be all the things that you're going to constantly evaluate. Again, what is triage? Process for managing mass casualty event. They're going to be evaluated. They're going to be sorted by urgency. And then the victims are going to be set up for immediate or delayed treatment. That little card that she handed you out. When you arrive on the scene of a mass casualty incident, when you begin triage, chances are you're going to have one of these tags. You got the original. You're going to have a handful of these with a little string on it. And these are in black and white, but the originals are colored. And they're perforated, so you can tear stuff and fold it and rip stuff. It's going to be part of your documentation. And I'm going to pass this around so they can see. And here's what you're going to do. And the way that you're going to do this is you're going to rip a section off based on what you classify them when you triage them. If they're an immediate, where they have life-threatening injuries, where, it requires an absolute immediate action to sustain their life, you're going to rip everything off but the red. So when the next person comes along, looks down at them and says, oh, this one's an immediate, they got to go. The second is going to be the yellow. They're going to be the delayed section. Their injuries don't jeopardize their life. They can be delayed, but they still have to be treated. They may have a busted arm, or they may have a broken tib fib, or they may have shattered their foot or something. They don't have to go immediately, but they do have to go. And then green are your walk-in wounded, your minor. These are the ones that are going to probably be on scene the longest. These are the ones that, if they have the ability, you can put them to work. Remember we were talking about in the beginning, don't assume that they're just going to automatically jump in there to help you. But they may need some direction. They may say, what can I do to help? And it may mean, hey, stick your finger in that hole and plug that blood. But then the last ones, and it's tough to make that call. The black, and those are the ones that are deceased. When you pull it off, everything but the black, they're dead. And whenever you go up there, you check, and there's no respiration. You open the airway, and they're not breathing. You check their pulse, and they don't have a pulse. You mark them as dead, and you go on to the next person. And we'll talk about triage some more later, but one of the things about it, and you'll see it again, one of the don'ts to triage is don't get tunneled in on trying to treat somebody during this process. It can get real easy if you see somebody and you think, all I can do, I'll just put this bandage on them real quick and then go on. You can't do that. Reason why is because you've got to be able to classify everybody and get them moved to their area. And we'll talk about establishing a treatment area in a minute. But you have to get this done rapidly. Because the faster you get them triaged and you get them moved to a specific area for treatment, then you can start putting your resources into place. Okay, when the paramedics get here, they need to go where the red section is. Okay, when the fire department gets here and they've got EMTs and first responders, they can go to the delayed in the green area. And of course, whenever the coroner gets here, he don't have to go through 100 people to get to the people he needs to pick up. So we need to try to get that done as quick as we can. And when you're doing this, anytime you suspect that it may be a terror incident, and I'm going to go even farther as to say, Lord forbid, a bomb blast. If a bomb goes off and you've got a bunch of people, you're going to have to hold back. Reason being is, how do you know there's not a secondary device somewhere? And so that'll be a stop point. Anytime that you've got serious foul play like that where mass casualties, you may have to hold up until we know it's safe to go in there and work. And then evacuate as safely as possible. We're going to get your guys' stuff issued to you pretty quick here soon. So anytime you get ready to do anything like this, fire suppression, treating people, always use your personal protective equipment, your PPE. Always use it. You don't know what germs some people carry. There's some funky stuff rolling through people's bodies in this world nowadays. And you don't want to get any of that into your body. So, helmet, goggles, your mask, your gloves, boots, your non-latex exam gloves. Always use non-latex, because we don't know in that environment who's got a latex allergy and who doesn't. So we're going to go on the premise that everybody's got a latex allergy. So always carry non-latex. Stop, look, listen, and think. When you get out on that scene, stop and look around and listen. Listen to what's happening. And then think about and process what you're seeing. Conduct voice triage. And what that may mean is, if you can hear me and you can walk to the sound of my voice. Well, your walking wounded will walk to you. Well, you have already just taken them and put them in a big old green section and said, go stand over there. So conduct a voice triage. Have them come to you. Don't go hunting for them, but call out and have them come to you. Start where you stand. Don't wade off into the middle of everybody and then try to do a pattern working yourself out. From right where you stand, this one, the next one, so on and so forth. And when you're developing that action plan of what you're going to do and working together as a team, you guys are standing there. You start where you stand. You just say, all right, you're going that way, I'm going this way, and then you work yourself down. Evaluate them and tag them. Treat eye victims immediately, but as the triage officers, you don't treat. You're the ones that are saying, hey, this one's an immediate, and somebody will come and get them and start treating them. But you keep moving, tagging people and evaluating them. And then one person needs to be standing near you with you calling results to them so that they can document it. Because as they're going down, you say you are triaging and you're standing back there documenting, and they're saying, this one's a red, and you're marking. That way, whenever the professional responders get there, you can say, okay, we've got 25 that are red, we've got 10 that are yellow, and we've got 30 over here that's in the green, and then we've got 4 in the black. If you hear a lot of radio traffic from EMS or fire or police, when they get on scene of a major accident, the police will sometimes tell their dispatch to advise EMS that we've got 2 red patients, letting them know that they are critical. Because police are also trained to triage in emergencies. So triage evaluation, when you're evaluating them at first glance, when you first get to them and you look at them, check their airway first, check the circulation, check their pulse, and then check their mental status. Grab them by the shoulder and just kind of, hey, can you hear me? If they're talking to you, that's a good sign. If they're completely, well, and you know, she's probably been taught what they call a sternal rub. Pinch them.
Stand behind them.
Yeah. Do the pinch up here. The old school way was take your knuckles and rub them on their chest. And that generally will wake somebody up if they're going to wake up. Do what you got to do to try to assess their mental status a little bit. Pitfalls. If you go at this without any plan whatsoever, and you have a half idea of who's hurt, who's not, nobody's really moving anybody anywhere, they're just laying there and you don't have tags on them, you're going to have to start the whole process over again. So always have that plan when you get ready to start doing this. I told you before, too much focus on one injury. Triage officers are not there to treat. They're to assign a category and move on. And it's tough. I mean, mentally, it's tough to sit there and you may have someone who is alert. They're oriented to what's going on. They may have an injury that is non-life sustaining. And they may be laying there, and even if a team of surgeons was standing there with them, they couldn't save them. It's tough to be able to look at somebody that's alive and talking to you and scared and rip that tag and put it in the black and go on, because you know they're not going to survive. But that's what the triage officer does. You can put it in the red, and if they turn into the black, but this is what you may face. If you ever wind up in a serious disaster like that, that's what you may face. And then treatment rather than triage as a whole. Don't get too wrapped up in trying to, yes, they have a serious bleed and you think you can get it stopped if you just take a few seconds to put that pressure on it or what the case may be. Tag them as immediate and move on. So, unit summary. You should be able to identify the 3 killers. What are they? Airway, circulation, and shock. Applying techniques for opening the airway. What are 2 that we talked about? Head tilt, chin lift, and the jaw thrust maneuver. Okay, controlling bleeding. Direct pressure. Elevation. A tourniquet if you're trained to do it. I would recommend everybody getting trained in that. I really would. They're fixing to make it a very easy process. It's going to be like a 3-hour course on how to operate it. What else besides direct pressure and elevation? Pressure points. Very good. And then treating for shock. We didn't talk about how do you treat it. We talked about the symptoms of it, but how do you treat it? There is a position called, and I'm going to try to pronounce it, I can't, the Trendelenburg position, where you raise their head and their body slightly elevated, and then you raise their feet. Now what are you doing when you do this? Putting all that blood right down there into the center of the body. Right there where those organs are that need it. What you're going to also want to do is you're going to want to wrap them up. Try to get them warm. Because everybody knows whenever you get cold, you start shaking, the body says, we got to move more blood, warm us up. So try to make them
But the
warm.
only time we would do any of this is after triage is done.
Correct,
So
yes.
triage is done, the responders aren't here yet, then we start all this.
Correct. And in the next unit, we're going to go more in depth into triage. Now that you know how to triage, we're going to talk about when you set up a treatment area and how you would do that and how you would orchestrate it. And in those treatment areas is whenever you would be performing these actions. And then conducting triage under simulated disaster conditions, which was what we're going to do during our practicals.
We're gonna do all the practicals at the end.
We are. We're going to do all the practicals at the end. We have 2 hours allotted. We do now have 4. Okay, awesome. The way that I want to try to do that is we're going to have an hour per station. We're going to do an hour for light search and rescue, an hour for fire suppression, an hour for triage, and an hour for med ops, where we can do that. So your homework assignment is to read over a little bit more into what we're going to cover next time. And what this is we're going to move it from part 1 to part 2. And looking at it, I know that it's a little bit longer than what this is. I told you this one was going to run pretty quick. The next one may not be quite as short. Anybody have any questions so far? All right, well, we're rocking right along, folks.